Whenever you're ready.
Sure.
You just want to make an announcement.
Good morning, everyone. I want to welcome you to the Community Practice on Autism Spectrum Disorder and Other Developmental Disabilities. Welcome to the people at our Waisman Center, and welcome to the people that are joining us throughout Wisconsin. Because we are broadcasting throughout Wisconsin, the lovely just sort of dusting of snow with an underlying just quarter-inch of ice underneath our cars and the roadways that we have in the Madison area is not true for the rest of Wisconsin. And so we're going to sort of go on hold for 5 minutes to give people a little bit more time to arrive at those sites that received a little bit more snowfall than we did, because we want to be able to have everybody in the room for the discussions when we do start the presentation. So we will reconvene in about 5 minutes. Thank you.
So, like, you know how you went for your internship, and I spoke to one of the classes about what we do. That's how she recommended. I didn't recommend her. Oh, yeah. So I think oh, sure, yeah.
James, welcome. Really well. The speakers were really
Overnight oats, milk, frozen fruit, and then I some mixed tea. So more like a shit. Like oatmeal. Toss in the virgin lettuce cook the oats. With the oats, milk, frozen berries, and like all the I mean, it's not. Right. I mean, this is breakfast. Yeah, it's not like a substitute for meal, right? Yeah. I mean, yeah. But I will be asking questions that we'll be discussing during updates some of the work that I'm doing. This event has to be a presentation, which I have was appointed member. If you want, sit up.
Oh, right here.
Good morning and welcome back. I realized I was a little more than a 5-minute break, and so I promised to keep my introductions and background information on the community practice down to a minimum so that we can get right into the speakers that you came here to listen to today and to talk about today. We have had a couple of sites check in with some photos of their gatherings. We've also had some sites check in saying they're experiencing some technical difficulties and have worked through them, and they're back online with us, which is exciting as anything. So just to give you a little bit of background, my name's Tim Markle. I am one of the co-chairs for the Community of Practice on Autism Spectrum Disorder and Other Developmental Disabilities. The other co-chairs are Ann Harris, who works for the Waisman Center Lent program. She is here at the Waisman Center site. And then Kelly Brodhagen is our parent representative on the steering team and also as a co-chair, and she is at the Appleton site. So if you see Kelly at Appleton, Wisconsin's SOAR site, tell her great job. She's doing amazing stuff with us. So we're led by the co-chairs lead the steering team. The steering team is made up by members of the community, and they are basically there to set the direction for the community of practice. If there's no real we are horribly grateful for the funding that we do get and grants that we get written into. If there is a backbone organization, and there is, we owe a lot to the Waisman Center, University Center for Excellence in Developmental Disabilities, Leadership Education and Neurodevelopmental Disabilities Program, also known as Wisconsin LEND. They have shared trainees with us, they have given us time, and we're very grateful for their support in being able to have this event today. The community of practice itself started 10 years ago when there was a federal grant given out to the state of Wisconsin to improve the service, the care circle, so to speak, of people with autism spectrum disorder and other developmental disabilities. And so a leadership team came together, and for the next 3 years, we did various activities, such as hold listening sessions throughout Wisconsin, so community conversations. We put together regional core teams in Southeast, Southern, Northern, and Northeast Wisconsin to try to get what was going on the ground. We met as a large group throughout the state to see if we could move a couple initiatives forward. We we collected a bunch of resources to put into a new database, and just a lot of great work along with the webcast series that is still available today that is some of the best people in the field talking about surveillance and developmental screening and what's the difference between what are we looking for when we're looking for early identification and monitoring, when we're monitoring, what is it that we're monitoring, what does healthy look like so that we can tell when somebody may be a little bit behind and may need some intervention. So those are still available up on the Connections website, the Community Practice website. But then one of the other initiatives was, hey, let's get people together at least 3 times a year. Let's learn together. Let's share together. Let's see if we could get some work done together. And after the grant ended, the people who were involved in the community practice said, you know what, this is working really well. We realize that there's no grant right now to keep this going, but is there a way that we can continue to meet as a community practice? And so the steering team reconstituted itself, some new leaders emerged, and here we are today. And where we are today is there are over 40 sites that are joining together for this meeting, for this event. There are we had originally around 900 people registered, but once we changed the date and all that, we're down to, I think, 732 exactly, according to what I was working on last night. So we'll see if they all show up. We know that weather is a factor. We know that changing the date is a factor. But I want to give a nice shout out to the site coordinators who have been able to not only plan this once, but then go back into their scheduling systems and find a room again and find time in their schedule again. So I do want to acknowledge them, even though this is probably something that if you go to professional school, you're not supposed to do. But here's who is listening today, all right? We have ABA of Wisconsin in Wauwatosa, the ADRC in Brown County, the ADRC in Door County, along with the Partnership for Children and Families, Barron County Developmental Services, CISA's 8, 9, 5, and 12 all have sites. That includes Ashland, Portage, Gillette, and Tomahawk. Chequamegon High School in Park Falls joined us last year and is back again this year. Cholita and La Crosse, the Elkhorn School District along with Lakeland School, Greene County Human Services, KJH Autism Services Madison, Lakeland Union High School in Minocqua, Mercy Health in Janesville, Mid-State Independent Living Choices in Stevens Point, Nicolay College in Rhinelander, Northern Wisconsin Center in Chippewa Falls, Oneida Behavioral Health in Green Bay, Oshkosh North High School, Shepherd's College in Union Grove, the Human Service Center in Rhinelander, University of Wisconsin Platteville, Milwaukee, Superior, Whitewater, and then Madison here at the Waisman Center. Very Special Arts Wisconsin, VSA Wisconsin, joined us as a site. Wisconsin Early Autism Project in Eau Claire, Madison, and Milwaukee. Westby Area High School, Western Technical College in Mauston, the Winnebago Mental Health Institute in Oshkosh, Wisconsin Indian Head Technical College in New Richmond, and then Wisconsin's Fox Valley Tech, SOAR, in Appleton, along with, I believe, Autism Society of Wisconsin joined in them in promoting that site. We did have a number of sites that were unable to reschedule that I do want to mention. Marathon County Health Department and the Northern Regional Center for Children and Youth with Special Healthcare Needs, Advocates for Healthy Transitional Living in De Pere, Greendale School District, Sheboygan County Health and Human Services, Tachita Correctional Institute, and the Hispanic Collaborative Network, Waukesha County Health and Human Services. Because of the date change, they were unable to join us on this date, but they put in a lot of work to be able to have the original site, so I want to make sure that we thank them. Most of all, I am astounded that our speakers were all able to find another day within 2 weeks. This is, however you want to, whatever your beliefs may be, it's amazing. And so I was really excited that they were all able to adjust their schedule. The discussion leaders, who sometimes are the site leaders, we will be following each presentation with 1 or 2 questions for the sites to discuss, because the main part about today's meeting is not the fact that we all get to listen together, which is great because we love having the same information, but that on a local level, you're able to take in and talk about what the speaker is presenting and how it applies to your local area. We're learning together statewide, but we need to apply changes locally. Waiting for someone to parachute in with the answers or to suddenly snap their fingers, or if you're a Harry Potter fan, if we could find the spell to fix the system, wouldn't that be great? But I don't think that spell exists. And so it's going to take work, and I believe it's going to take work on the local level and working together with partners that we know and partners that we haven't thought of that we need to include. So thinking outside the box. But change is going to be made on a local level with families and professionals working together. And so that's why we do this distant event, because there's no way that we're going to be able to get around to 40 places. But do we want change to occur in 40 places? Absolutely. Does change need to occur in 40 places in Wisconsin? And more. And so thank you so much for being part of this event. Title V, Maternal Child Health, the statewide children and youth with special health care needs network and program is very much a part of this day today. Also like to say a special thank you to Rachel Kramer, a LEND trainee, who has managed to get this off the ground in more ways than I ever imagined possible. Her success has led to my headaches. So very grateful for the work that she has done and where she has helped us to go. Sonia Etzel and her team. Sonia is an administrative guru that this day would not have been possible. I would not be staying without her. Clark Kellogg and the Waisman Center communication team, who constantly is getting how many people? How many people? Really, Tim, how many people do you think are coming? And so we're excited that we're able to be in the Wiley room. I love this location. Would also like to thank the other people that support behind me, the Southern Regional Center for Children and Youth with Special Health Care Needs, the Youth Health Transition Initiative, the Genetics Integration Systems Integration Hub. All these people expect a little bit of time from me, and it would be wrong for me to say that I've given them everything in the last couple of weeks. This has taken a lot of time and a lot of effort by a lot of people, and so I appreciate the patience that they have shown, knowing that, yes, I know you have emails. I will answer them. I promise. I will answer those emails. That's our introductions. I wanted to make sure you knew of a couple events coming up. The first one is the 30th Annual Autism Society of Wisconsin Conference. It will be April 11th through 13th at the Kalahari Convention Center. We will send out links to how you will be able to sign up when we send out the evaluation feedback form. But if you feel like taking notes, it's www.asw, the numeral 4, autism.org. It's an excellent conference. I love going every single year. The other conference that you will find me and some of the people in this room at is the Circles of Life Conference. That will be held May 2nd through 3rd, and that's going to be held at the Holiday Inn at Stevens Point. So wherever you are in Wisconsin, hopefully you can make one of these two. Their registration is at www.circlesoflifeconference.com. So I encourage you to check those out. I believe both have scholarships available. More information is on their website. I am now very tired of listening to me speak. I want to get back to my coffee. And so it is with great pleasure that I introduce a friend, someone who is a family advocate, and, well, just overall a really neat guy. So enough about that. I'd like to introduce Hugh Davis from Wisconsin Family Ties, talking to us about barriers to accessing mental health services. Thanks, Hugh.
I'll probably temper your enthusiasm after you see my presentation, Tim, but I appreciate the intro. Is there anything I need to know?
Oh, I'm sorry. You can...
What's page down? There's no page down on this. Oh, there it is right there.
Use this or this.
Okay, got it. Got it. Thank you.
Yep. And for all future speakers, you can either use this or the keys. Okay, good. We've covered that. Thank you, Hugh. My bad.
It's okay. So I got a little bit more nervous as Tim listed off all of those sites that are there, because I'm going to talk about some barriers from a parent perspective, and some of those barriers don't sound very flattering sometimes to providers, but I'm confident that every one of the providers that are here today are on the excellent end of that spectrum, so that shouldn't be a problem. But it also strikes me that the experts on this subject today are in the audience and not really the speaker. We could probably spend the whole day in conversation amongst ourselves about the barriers that people on this webcast have experienced. And I admit that I really struggled with this topic. And in the end, I decided not to focus on barriers to access that are often brought up, things like scheduling, location of providers, cost, insurance, workforce shortage. Those things have been talked about time and time again. And so today I decided to instead focus on some things that, barriers that I've experienced as the parent of a young adult with autism, as well as some things from my experience with Wisconsin Family Ties. And I actually am going to spend more of the time talking about some of the systemic barriers that we've experienced through Wisconsin Family Ties. And I apologize if I take a break every now and then to grab some water or a cough drop. I am getting over a cold. If my voice gets a little froggy, I apologize in advance for that. So let's start first with the competence and fit of providers. You know, just like any other profession, there are good mental health practitioners, and then there are the others that are not so good. You know, there also may be providers who are very competent but are not a good fit for your family or for your particular child. And so I tried to focus on a few things here, and I'm not going to go into great depth on those, that you may want to consider as you're either selecting or developing a relationship with a provider. So first area is skill and approach. And the thing that I think of the most is an experience that I had many years ago when my daughter was 9 years old and experiencing significant anxiety. It came on very suddenly, and it started with a stranger danger presentation at school, and within a week she was refusing to go outside and play in the backyard. So we ended up contacting some people trying to find someone who was a good fit, and we found a psychiatrist that was highly recommended. So we had this appointment. We sat down. I'm there with my 9-year-old daughter, and the psychiatrist wants us to go through a very detailed family mental health history. We have a significant mental health history, particularly on one side of the family, and that includes the suicide of my daughter's aunt. That suicide took place just before she was born. And at the age of 9, and a kid who was having anxiety, we had not broached that subject with her yet and talked to her. And so I told the psychiatrist, you know, I'm not really comfortable in talking about all of this detailed history with my daughter here. And instead of acknowledging my concerns, he just gave me his philosophy, which was, well, I think it's a good thing for kids to hear this family history. I'm sorry, that's not your call. That's our call as parents. And so, you know, finding out these things, and sometimes, you know, you don't find those out ahead of time, but finding them out as you're developing a relationship, and it's okay to not go back. It's okay to find somebody else, which is what we did in that case. Another area is what I call philosophy, and when I think of philosophy around children's mental health, the thing I think of most frequently is their view of behavior. And you know, if you look at the work of Ross Greene, he talks about really two different competing philosophies around behavior. That is, that kids do well if they can, or kids do well if they wanna. And there are practitioners out there on both sides of that fence. And if you if you subscribe to the philosophy that all my kid needs is a little bit more motivation and then he or she will do better, then that's fine to find somebody who believes in that philosophy. But if not, you're going to have an inherent conflict if you have a differing view on challenging behavior. So that's an important thing to find out as you're selecting providers. Over-reliance on medication. There actually is research that shows that providers are more likely to prescribe or recommend medication for kids on the autism spectrum than behavior therapy. So again, another thing to consider as you're looking for providers. Family-driven perspective. Do they believe that parents are part of the solution, or do they believe that parents are part of the problem? And I'll admit, as a parent, sometimes I'm both, right? But I like to think that I'm much more part of the solution than part of the problem. And how will those providers communicate with parents? The law used to be in our state that minors age 14 or above could consent or refuse mental health treatment despite the wishes of their parents. That law was changed in 2005, but we still have a number of mental health practitioners in the state who continue to operate under the tenets of the old law. So it's really important for you to understand your rights when it comes to informed consent and on whether you're going to consent for treatment or refuse certain kinds of treatment. And then finally, the thing I wanted to mention is finding people who can, who are experienced enough or have had the experience to understand some of the unique ways that people on the autism spectrum communicate. I remember when my son was 3 years old and went to the pediatrician for a well check, and the nurse told him to hop on the scale. For a kid with autism, you take that literally, and you hop on the scale. I also remember in my work at Wisconsin Family Ties a number of years ago when we were working with a team, and this was a team where Child Protective Services was involved with a family. And the mom of these kids was in this meeting, and she was relating how things were going. And in the course of that conversation, she mentioned that she and her kids had gone to visit a man at his house. Well, the child welfare worker blanched immediately and said, "What are you talking about? That was, we told you that man could not be in your house." And the professionals around the table couldn't understand why this mom would willingly talk about going to visit this man at his house when she was told that he couldn't be in her house. Well, it was clear to me, because I had a kid with autism, that those were two different things in her mind. She saw absolutely nothing wrong with going and visit the man in his house, because what she had been told was, he can't be in your house. And so, finding people who can understand those kinds of nuances in how people communicate are really important, particularly with kids who are on the autism spectrum who tend to, I continue, my son is 22 years old, and just had another example recently with all of this weather about the difficulty in generalizing certain kinds of statements. So when the temperature was well below zero, and my son, who does have his driver's license, drives only in the local community, and he has a very part-time job about 1.5 miles away. And my wife told him on one of those days that was tremendously below zero that when you start the car, let it run for a while. All right, let it run for a while and warm up. And so he did. The next week, when it was about 40 degrees, he went out and started the car and let it run for a while. He didn't understand the context that's different when it's 40 degrees and when it's 25 below zero. Unfortunately, the day that it was 40 degrees when he did that, the car was in the garage. But he figured out quite quickly as the exhaust started to gather in the garage that he better open the garage. So, it could have been a tragic situation, but I've grown up with him for 22 years. I think we know him really, really well, and yet just some off-the-cuff comment was totally misinterpreted by him because he couldn't understand the context. So, enough of that. I've belabored that. So I also wanted to talk about some of the challenges when it comes to eligibility and rules around programs. And when we're talking about mental health programs in our state, the thing that pops immediately to mind is a program called Comprehensive Community Services. And the reason that that is important is because about 6 years ago, the state decided in their biennial budget to the state would cover the non-federal portion of this Medicaid-funded program. Prior to that, in our state, mental health services, if it was a Medicaid benefit, the non-Medicaid portion, not federal portion, was always covered by counties. And so now the state picks this up. This creates a huge incentive for counties to utilize comprehensive community services as their primary mental health program, public mental health program. CCS is a program for the lifespan, so it covers from kids through adults. And it is defined and governed by an administrative rule, and that administrative rule is DH 36. If anybody wants to find out anything about it, just Google Wisconsin DH 36 and you can read that. So there are a few things that we've seen over time or heard from families as we work with them. And one of those is around the area of eligibility, where some families have been told that their child is not eligible if they have an autism diagnosis. That is not technically true. They do have to have a according to the rule, a diagnosis of a mental disorder. There's nothing that says that autism disqualifies someone for that. And quite often, they probably are looking for a more traditional mental health diagnosis. But the vast majority of kids, in fact, every kid on the autism spectrum that I've seen or worked with over the last 16 years has co-occurring anxiety and depression, and certainly at a diagnosable level. So, so this idea of autism disqualifying somebody from being in the Comprehensive Community Services program is not true. Also, there is a discrimination statement in the rule which says, among other things, that you can't be denied because of disability, so that you can't exclude because of autism. You do have to meet the criteria, which is, again, a mental disorder or a substance use disorder. In the second area where we've heard some concerns about barriers is in the area of service transition. And so families who have previously had services and now are going to be getting services under CCS, and some have been told that they have to give up their intensive autism service or their ABA service. And that, again, is not true, and there is a bulletin that talks about that, and I've listed it here, Forward Health Update 2014-42. You do have to use the psychotherapist that is a contracted provider in that CCS network. So if you're currently using a psychotherapist and they're not in that network, you may have to give that up, but you do not have to give up your ABA service. The next area is informed consent. When CCS was developed, it was, even though it was designed for the lifespan. It was really designed using a whole lot of adult language. Consumer is a term that is used in the mental health world. It comes from the adult mental health world, used to mean the person who is not only receiving services, but making decisions about those services. Our contention is that when it comes to the kids' world, that the service recipient and the consumer are sometimes different, that the child is the service recipient and the parent is the consumer. They're the ones who are making decisions about those services. They're the ones, in cases where there are services to be paid for, that are paying for those services. And so CCS is identified as consumer-driven, and a lot of the training that the various CCS sites get in this program emphasizes this consumer-driven perspective. Unfortunately, what we've seen happen, and this is believe it or not, a true case, there was a situation where a 7-year-old child said in a team meeting, "I don't want to do this anymore," and the CCS site disenrolled him from the program. I don't believe 7-year-olds are the ones who should be making those decisions. I think their parents ought to. And so that's something that you should be aware of and continue to push on if you have a CCS site that is having kids make decisions that are not developmentally appropriate. Interestingly enough, within the CCS rule, and I put the citation on this slide, there is a notation that says that family members are also considered consumers. So if this is consumer-driven, then it clearly needs to include the family members in that decision-making process. And finally, the thing that I want to talk about is choice. We know that there's a lack of mental health practitioners and providers throughout our state, and it's particularly challenging in certain parts of the state. But CCS does have right in the rule that there should be choice in selection of team members, that is, the people that you want to have meet periodically to look and develop a plan and assess that plan, in the services that you receive, and in the providers. And so we think that that's a really important concept in CCS. It's something that's all too often not emphasized as part of the training or in the rule, but it is there, and I think choice is a really important aspect for families, particularly with kids with challenging behavior, including those on the autism spectrum. So, these webcasts are always interesting because you feel like you're just talking. I look forward to the conversation time afterwards so that we can get a little bit of feedback. But the next thing I wanted to talk about was systemic barriers, and I like this particular definition of system. I like the idea that a system creates a unified whole. I like the word harmonious. And so given this definition, let's take a look at Wisconsin's children's mental health system. So I'm going to lay out some of it's a simplified graph, but I'm going to lay out some of the elements of the children's mental health system on this graph, and the vertical axis on the left represents the degree of parental control, and the horizontal axis is the intensity of mental health needs. So we're going to look at some of the main components of the mental health system and see where they fall in terms of the degree of parental control that you have, as well as the intensity of need. All right, the first is outpatient and medication services, and this includes things like individual therapy, family therapy, group therapy, psychiatric services where your medications are managed. These are services that are typically selected by parents, and the decisions to continue are with the parents. So there's a high degree of parental control in selection and continuation of those services. The next area is called community-based support programs, and so that would be things like this, the CCS program that I talked about before. Another program that a lot of kids with mental health needs access in the state is called Coordinated Services Team Initiative, CST. So that would fall into this, this bucket as well. The next area, if a child's needs get to a point where they can't receive the needed care while they're at home, then we get into residential-based services. And these are things like group homes, residential care centers, therapeutic foster care. And while technically in our state, parents retain legal custody, they don't have physical custody, and in reality, they end up relinquishing quite a bit of the authority they have over their child while their child is not in their home. Unfortunately, in our state, if a child has intense needs and they have done something that can result in criminal charges, they may end up in a juvenile detention facility or in corrections and receive mental health services through those institutions. And clearly, parents are no longer making the day-to-day decisions for their child when they're in those settings. And finally, there is hospitalization, and the degree of parental control with hospitalization is really dependent on whether that's a voluntary hospitalization or an involuntary hospitalization. And I'm not going to get into the whole mechanics of Wisconsin's mental health law, which is Chapter 51, but all I wanted to do was signify that there are situations where there is involuntary hospitalization, and again, there's not a great deal of parental control in those situations. You know, while we refer to this set, or this kind of continuum of services as the children's mental health system, in reality, it is really multiple systems. For example, the residential services are part of the child welfare system. The child welfare system is primarily tasked with addressing child abuse and neglect. So if your child's needs are such that they require temporary placement outside of the home, you will have to file what's called a file a CHIPS petition with the court. And CHIPS stands for Child in Need of Protection or Services, and the form typically requires you to stipulate that you are unable or unwilling to provide care for your child, which is highly offensive to parents who are simply trying to access services their child needs because of the intensity of those needs. And obviously, placement in detention or corrections is part of the juvenile justice system. You know, there's lots of research on that reaches a conclusion that in the United States, not just here in Wisconsin, that our correction system is the de facto mental health system. And it's no different here in Wisconsin. While I don't think the Division of Juvenile Corrections is doing the assessment tool that they used to do, but and I have no reason to believe that things are any different, but several years ago, when they were doing an assessment tool to assess mental health needs, they found that over 75% of the boys who were in the state juvenile corrections facility had mental health diagnosable mental health needs, and 100% of the girls had diagnosable mental health needs. So it's clearly the de facto mental health system here in Wisconsin as well, and it's that way for adults also. So why is our system constructed this way? Well, you would hope because it's best for kids. But that's not the case. So if it's not best for kids, maybe it's best for providers. And while it's probably a little bit better for providers than it is for kids, that's really not the case either. So, you know, if we remember our definition of system, you know, a set of things working together as parts of a mechanism or an interconnecting network to form a unified whole, you know, maybe it's most efficient. But that's not really the case either. And maybe it's cost effective, but that's not the case either. So, so why do we have this kind of system then? And I've thought a lot about this, and I can only come up with one reason that our system is this way, and that is because these are the structures we have. There's no other reason. We have a child welfare system, we have a juvenile justice system, we have state statutes, and it's because of this that we have this system. This is not what you would design if you were starting from scratch, clearly. And, you know, Tim basically gave my presentation this morning talking about the need for system change and how it's pervasive across the whole state. So, you know, having come to this conclusion, I decided, you know, maybe despite all of these inefficiencies and that it's not really oriented towards kids and families, maybe we're producing good outcomes. So I decided to take a look at that as well. This is a 10-year view of access to public mental health services for children ages 0 to 12. The rates that are shown on the vertical axis are per 1,000 children with what's called SED. SED is a term that the federal government uses. It stands for serious emotional disturbance. I hate that phrase, have always hated that phrase, but it's pretty ubiquitous across the federal government. Interestingly enough, you know, it's based on a definition. The definition that the Center for Mental Health Services, Federal Mental Health Center for Mental Health Services uses for SED is that they're persons from birth to age 18 who currently or at any time during the past year have had a diagnosable mental, behavioral, or emotional disorder of sufficient duration to meet diagnostic criteria that resulted in functional impairment which substantially interferes with or limits the child's role or functioning in family, school, or community activities. That's a pretty broad definition in my book. And while there have been people who said that kids with autism are not kids with SED, there actually is a federal court ruling that identifies kids with autism as part of this umbrella category SED. And that ruling is in the Rosie D. decision, in case anybody's interested. It was a case that was in Massachusetts about a decade or so ago. So clearly, we have a ways to go in access to services for kids, for our younger kids in receiving mental health services. So how about adolescence? And we can see that the picture is not really any better there. We're significantly below the national average. So now let's take a look at those community-based mental health programs and see, are we utilizing those any more than others? And you can see, I think that it's interesting that I've got the years switched. I apologize on that. But we're clearly below the national average on that as well. And also the one area where we beat the national average, and over this period of 6 years, we're about 3 times the national average. We put more kids in state mental health institute than other states do. It's the one area that we outperform the national average. So, not only do we have substantially lower rates of access to those services than average, we also have among the lowest parental satisfaction with outcomes from public mental health services in the nation. I have looked at selective years over this 10-year period, and we did find that Wisconsin was actually the lowest in most of those years. So if we're going to transform our children's mental health system, then we need to make sure that we understand what contributes to good outcomes, because clearly we're not doing it right now. There has been a lot of research that's been done in the last several years. And this chart comes actually from the UW Population Health Institute, looking at what kinds of factors contribute to health outcomes. And this same kind of work has been repeated by many researchers across the nation, and they've come to these same conclusions. And what it finds is that roughly 40%, the most influence on healthy outcomes, come from what are called social and economic factors, collectively referred to as social determinants of health. Twice as much influence on health outcomes as clinical care. Yet, if we take a look at where we spend our dollars, we spend it exorbitantly on clinical care instead of on those kinds of social supports. A major component of the social determinants is social connectedness. And this includes the quality of family and community support and civic participation. And so we, about 3 years ago, we did a research project with the Medical College of Wisconsin, and there were 3 nonprofits that were also involved. And we wanted to conduct a study to see what recipients of mental health services ranked, what they felt was most important. And the study found that out of an array of 11 service options, that peer support was identified as respondents as the most important service. It is identified as the most important service by a more than 2-to-1 margin over the next, which was psychotherapy. These results were consistent with the SAMHSA 2016 Awareness Day short report, in which parent and caregiver support was rated as more helpful than respite care, case management, or individual and family therapy. In our research in 2016, respondents overwhelmingly indicated that peer support helped them feel less alone and isolated, connected them to resources, and empowered them to find their own solutions. And interestingly enough, one of the other things that this research, and it's not on this chart, but one of the other things that we wanted to find out was in the cases where people had received peer support, were they being referred to other mental health services? And in the vast majority of cases, that happened. In those cases where people had been referred to other mental health services by their peer support worker, the engagement rate was 96%. That engagement rate surpasses anything that we could find in the research literature, and surpasses it even when there are co-located primary care and mental health care physicians, and a warm handoff, that is a walking down the hall and introduction to the mental health provider, happens. This was a higher rate of engagement than even in those situations. So, this is just one element of those social determinants. But there clearly is some compelling evidence that these social determinants really do make a difference in the lives of kids and families. The respondents say so, and the data also say so. So, it appears that Wisconsin's children's mental health system is insufficient. We have among the lowest access rates in the nation. It's ineffective. We have among the lowest rates of satisfaction with outcomes. It's investing in the wrong things. We don't prioritize the things that people need. And with large, intractable structures in place, and I have to admit, the inexplicable inactivity on the part of the responsible people at DHS for mental health, the only way things will change is if we collectively demand it. And so we at Wisconsin Family Ties would like to invite you to join us in creating a network of concerned individuals and organizations in reimagining human services. We envision a system that provides services and supports of sufficient duration and intensity to permanently alter the trajectory of our most at-risk youth. We want to ensure that we never forget the human part of human services. We want a system that's built on deeper understanding of children and families and less judgment, and a system that views relationship as the intervention. One of the areas where we're going to start is to advocate for creation of a separate children's mental health code and statute. Wisconsin's Mental Health Act for persons of any age is called Chapter 51, as I mentioned before. It was enacted in 1975. Since then, our understanding of child and adolescent brain development has grown exponentially. We now not only know what works for adults is different than what works for kids, we know why. We know that kids are not little adults, and in Chapter 51, because it's all just one code, that's really what they're treated as. In the intervening 40 years since its enactment, Chapter 51 has been altered numerous times, and it leaves a tangled web of cross-references and convoluted provisions. And so we're looking to create a child and adolescent mental health code separate from the current Chapter 51 that ensures these basic things. The residential treatment specifically designed to address mental health issues. The model that we have, I mentioned it earlier, the model that we have in Wisconsin is the specific model is called residential care centers, and those are really designed to rely heavily on behavior modification, not to address specifically mental health issues. So if any of you are interested in that same vision for human services and children's mental health, we invite you to join us. All you have to do is simply drop an email to our policy director. Her name is Joanne Yunke. I know it looks like junk, but it's not. Joanne Yunke, and her email address is joanne@wifamilyties.org. So that's all I have today, and I would like to thank Tim and the planning team for allowing me to speak, and it's been a great privilege to be with you today. Thank you. Sure, if you'd like. I know I'm a little early, right? Yeah.
So one of the things that we've asked the different speakers to do is come up with some sort of follow-up questions so that those at the viewing sites will have some direction and focus. But of course, we want to respect the local viewing sites. If there is a topic that is coming up at your local site, to please feel free to engage in that. This is not a my way or the highway sort of program. So with that, I just want to check with Hugh to see if there was from his presentation, stuff that at the local site may be able to be discussed to start to move us a little bit further down the line to healthfulness. I love the way that you brought in the social determinants of health. I think that's a really important framework to look at things. Health equity is an important framework to look at things. And I haven't heard it applied too much to the mental health system. So I really enjoyed that connection, because health equity is very important in a lot of other areas that I work in. But that being said, just trying to give you a little bit more time to formulate any questions. So anything that you think the sites would benefit from discussing? Remembering, of course, that we'll then be having that discussion here, so. Yeah.
Well, I kind of ignored that task of identifying questions. I thought it would be rather presumptuous of me to come up with particular questions. I have some personal interest in finding out if what I talked about today is consistent with what people have experienced. I'm always cognizant of the fact that at Wisconsin Family Ties, because we are we're a complaint-driven or an issue-driven organization. That is, people are not going to call us when things are going well. And so I recognize that my view might be a little bit skewed because of that. But, we do work with 600 to 700 families each year. And so I think that that's a pretty good sample size to be able to draw some conclusions. But I am curious about whether, people at sites, that might be something that they talk about. I'm also interested in, and this is maybe the big question that is really, really hard to answer. How do you, and you kind of alluded to it in your welcome, Tim. When we're talking about these things, we have these very complicated structures in place, and yet they're not really meeting the need. The evidence is really pretty overwhelming that it's not meeting the need. How do we go from that to something that does meet the need? How do we get not only the political will, but the public will to push for something like that? I think that would be a really interesting discussion. I don't have all the answers to that. Maybe somebody out there has something that would really help us move that forward in a compelling way.
I think those are excellent questions, and with over 700 people spread out today throughout Wisconsin, it's possible that somebody has an insight that we haven't come across yet. So I'm hoping that maybe we'll be able to receive some of that input. And so I would ask that the sites, if you have a note taker as well as a discussion leader, would be fantastic. But if there would be some way, especially, we would love to know, are the barriers that Hugh was talking about, are those relevant in Park Falls as they are over in Milwaukee? Are there other barriers that maybe are more at the forefront for your community? We would love to know about those. The way you're going to let us know is to take notes and send them in. This is a one-to-many broadcast, and so we're not going to be holding a discussion with 700 people. As fun as that would be, we're not going to do that. And so please feel free at your sites to discuss the barriers, the local barriers, along with how do we get to a system that's going to work. I love the word harmonious. If we could have the system working harmoniously, that's a fantastic word. So we're going to go ahead and we're going to stop broadcasting so we can have our own discussion here at the Waisman Center site. The plan will be to have approximately, let's go 15 minutes for this discussion, and then we're going to take a 10-minute break, and so we'll plan on coming back online at 10:05. So we will be reconnecting and beginning the next speaker series at 10:05. Please feel free to take care of yourselves at the site, and we look forward to your answers. Thank you so much for being here for this first part. We'll see you at 10:05. Thank you.
craziness of white culture and all the stupid things that white people with autism do. Thank you. Because I didn't want to make a racial I wanted to make a racial fun of in the end, although we never spoke again, we both disappointed, and I said, but a way of challenging those barriers was by finding ways to make how pages understand how they I'll never forget when I said about how that shot how the African Americans has such a shot and so things he did, which whether or not I agree with it, it's like one person who is not your race tells you and I asked him, sorry, you know what? Such people of color that just what they shun me. That I not offended by the racist slur that applies to people that are
All right, welcome back to the Community of Practice on Autism Spectrum Disorder and Developmental Disabilities. Today we're talking about access to mental health services for those on the autism spectrum and other developmental disabilities. Had a wonderful first presentation along with a really great discussion, and I'm going to make every other site out there jealous, but apparently there's cookies in the back, which I did not plan for, but I'm happy about. So I'll apologize to my next presenter, said I will not be here. I will be eating cookies and refilling my coffee. We have had some sites send in some pictures reflecting what is going on, and my notes of who are not legible at this point. So I will try to let you know who these sites are at a later time. But we do have, again, around 40 sites across Wisconsin. People just gathered together. Oh, look at that buffet in the back. Nice job. It looks like a resource table. Well done. And then another really nice conference room, and all these people kindly shared their photos with us so that we could feel more connected to our friends and colleagues across the state. As you could tell, not by looking, but as the people that are just in the room here at Waysman, and I'm sure it's the same at the other sites, is the community practice does not, people ask me, who's invited? And then I usually say everyone. And they're like, no, no, no. Who's going to get the most out of it? Everyone. Is we believe that great things happen when we get the parents, the families, the self-advocates in the room with the educators, with the researchers, with the physicians, with the social workers, with the school workers, is that we begin to think differently when we get out of our own little groups. And I find that very healthy. Before we start the next part of the presentation, I just wanted to read a note from Kenya Bright. Kenya is the section chief for the Integrated Services section of the Bureau of Prevention, Treatment, Recovery, Division of Care and Treatment Services. And I had reached out to Kenya and her team to get a little bit more information about comprehensive community services, because we had a lot of questions before this event was on about that interaction and comprehensive community services. Kenya was not able to be with us today, so she gave me permission to just sort of give a little bit, a statement basically, to try to help us understand more. And she acknowledges, this is a complicated situation. Individuals with autism cannot get CCS services for autism. However, individuals with autism and a mental health or substance use disorder can receive CCS services for the mental health and substance use disorder only. To receive CCS, the individual or parents need to apply for CCS with their county of residence. This is a multi-step process, one of which is they have to be found functionally eligible for CCS by the Children's Functional Screen, or if an adult, the Mental Health and Substance Use Disorder Screen. If they are found functionally eligible, then the CCS program will proceed with doing an assessment. During that assessment, the mental health professional must find that the person is also eligible using the criteria for CCS, and most importantly, that the person needs more services for their mental health and substance use disorder than outpatient services. There are times that person may have needs for services that CCS provides, but those needs are caused by autism or intellectual disability and really only need outpatient services for their mental health, substance use disorder needs. If the person does not fit this criteria, then the person is not eligible for the CCS program. CCS can help with mental health substance use disorder issues, but only if the issues are not caused by autism. For example, if the person needs assistance with social acclimation or organization, the reason for these needs has to be clearly linked to the mental health substance use disorder and not to their autism in order for CCS to provide services to help. For individuals who have both autism and mental health substance use disorder, this could be a bit tricky. CCS programs are cautious regarding this because they cannot bill Medicaid for services provided for autism. She is open to continued conversations. She provided the contact information. If you would like to talk to me afterwards, if you have more questions for Kenya, I'll provide that contact information. One of the things that I appreciated about, I had a number of phone calls with Medicaid Services, who is here today, as well as other people over at DHS. And as I was talking to Hugh at the break, 10 years ago, when I would have some conversations with people that are no longer with the Department of Health Services, there seemed to be this idea that this is a system, deal with it. It's what we have. What I am getting when I talk to those professionals, the section chiefs, the people working with these programs, is this new acknowledgement that it's not perfect, that it could be done better. And they're working on trying to figure out how to make it better and how to make it work better. And I got to tell you, I didn't see that a lot 10 years ago, but I'm running into it now with the people that I'm meeting to, and that's very encouraging to me. So I'm grateful for that. So besides CCS, there are other options to help access mental health services. I want to highlight one that I promised I would highlight. It's called it's called CPCP. I will not be able to get the words out. But it is a unique program that has been piloted throughout Wisconsin, that is now expanding throughout Wisconsin, where primary care physicians can sign up to be part of the CPCP program, and it will give them access to child psychiatry. And so they are able to call and talk over their patients, so that what we have is we have primary care providers being able to feel they are capable and supported in providing some mental health services to their patients. It goes along with the model that we promote nationally called Medical Home, where the parents are receiving coordinated comprehensive services from a family-centered point of view. And so we're very excited at that program. So there are some good stuff moving together. Would now like to go ahead and bring up our next speakers, Daniel Kiernan and Dr. Pam Lano, who I just learned I've known for 10 years, but she went and changed her name, and so I have no idea who she is. She insists she's the same person, but I don't know. But I'm excited to have her back because she has been involved with the community practice, I believe, almost from the beginning, possibly the original steering team. And so I guess it's exciting to have you back, Pam, as part of the community practice. So thank you guys very much for being here.
Thank you for the introduction, and thank you for your time today, the opportunity to provide some information about the Medicaid program in Wisconsin, the mental health services, and broader behavioral health services that we cover. So I'm Daniel Kiernan, Section Chief for Behavioral Health Policy in the Bureau of Benefits Management, in the Division of Medicaid Services in the Department of Health Services. What all that means essentially is I work with a team of policy analysts and clinical consultants in drafting the coverage policies that Medicaid has for behavioral health, a term that we use broadly to describe mental health treatment, substance use disorder treatment, as well as a specific benefit called behavioral treatment. And I'll get into some of those benefits in a little bit. Those are all what we call non-institutional benefits, so I won't be talking about hospitalizations today, other institutional types of care, talking about those outpatient or home and community-based services. And then Dr. Lano will be joining me a little bit later in the presentation once I've gone through some of that benefit structure to talk a little bit about the authorization process that Medicaid has, where we look at Medicaid members, really trying to look at that individual perspective of a Medicaid member, not just kind of from the benefit silos, for lack of a better word, that we have. So I'm going to go out on a limb here, see if I can follow up on that CPCP. I'm going to guess that we're talking about Child Psychiatric Consultation Program. Yes. Which is a fantastic program, the state's funding, which I think we've heard great results from so far and really appreciate the availability of that resource. That should be on the Department of Health Services website if you're looking for how to connect to that. Want to acknowledge we didn't really coordinate too much as speakers today, but I appreciate, Hugh, your presentation. I think it really does frame what I'm about to talk about really well. What I'm thinking of is that system chart that Hugh had, that axis of parental control and intensity of services, and he highlighted the child welfare system and the juvenile justice system. Some of the components there that weren't highlighted were the outpatient, the community-based supports, the hospital services. That's where the Medicaid program comes in. That's another component of that system. And so I am going to be talking about the nuts and bolts, the restrictions, the constraints of the services that we cover within that Medicaid program. But I do want to acknowledge that we recognize the importance of Medicaid within the broader child behavioral health system. Nationally, Medicaid is the single largest payer for mental health services. That's across all ages. It's about a quarter of total national spend on mental health services, but there's no other payer that has a higher percentage of total spend. So we know that Medicaid policies do influence and impact how mental health services are covered and received through other health insurance programs. And that's a role that we recognize and try to appreciate in the work that we're doing. So again, as I mentioned, I'm going to do an overview of Medicaid, a description of the services that we cover, let Dr. Lano speak a little bit about some of those clinical considerations, and then we have a split session today, so acknowledging Dr. Mortal will be following us as well. What is Medicaid? Medicaid is a federal state program that is authorized at the federal level under the Social Security Act, just over 50 years old now, and administered at the state level by the Department of Health Services Division of Medicaid Services. What that means is there are federal laws and regulations that apply to the Medicaid program, as well as state laws and state regulations. Every state in the country operates a Medicaid program. They all operate them in distinct ways. Medicaid enrollment, there's a wide variety of eligibility categories for Medicaid. You can be eligible based on income, based on non-income factors, including disability. And in Wisconsin, I think really what I want to highlight here is the end of this slide. You might be enrolled in Medicaid as a Badger Care Plus enrollee. You might be enrolled as a EBD Medicaid or an SSI Medicaid, a Katie Beckett Medicaid. Those are all terms that refer to different aspects of eligibility. The Medicaid program in Wisconsin has worked to develop a single set of benefits that is the same across all of those eligibility categories. So no matter how you became eligible for the program, the set of services you receive once you're eligible should be the same. Another concept that I want to just kind of put out there, Medicaid delivery systems. There are two main delivery systems. We have what's called the fee-for-service system, where a healthcare provider provides a service, sends a claim, an invoice to the state, and we pay that provider directly. There's also the managed care system, where the member receives the same service from a provider. That claim goes to a health maintenance organization, HMO, and then the department contracts with that HMO and reimburses the HMO for the services that they've covered. The services are the same, whether you're enrolled in fee-for-service Medicaid or managed care Medicaid. However, and I'll get into this, it's particularly relevant in the mental health and behavioral health world. Some benefits are available on a fee-for-service only basis. Some benefits are through managed care. And I think to the intent of today's program, one of the questions that we were asked is, how do I access mental health services? This is important to remember. If you're in an HMO and the service is covered through managed care, that HMO is someone you need to interact with to connect to that service. If you're in fee-for-service, the provider is the one that you're connecting with directly. So acknowledging that there may be multiple parts of that system you need to contact to access those services. So as I mentioned earlier, we have a spectrum of behavioral health services that we cover. Again, using behavioral health as a broad term, and then here we see behavioral treatment. That is a specific benefit designed for adaptive behavior assessment and treatment. The model that we see most commonly for behavioral treatment is ABA. It is designed to be agnostic, but that is the treatment modality that we see most frequently and is evidence-based, approved by the Medicaid program. Additionally, we have outpatient services, intensive in-home services for children and youth, psychosocial rehab, day treatment, and crisis intervention. I'll give a little bit more detail about each of those. Behavioral treatment potentially is the benefit that many of you listening are most familiar with. This is a benefit that was created in 2016. Previously, the Wisconsin Medicaid program had covered what it called autism treatment under the Children's Long-Term Community Supports waiver. A federal change in policy guidance allowed us to cover treatment under this benefit, under the state plan, so that all individuals in Medicaid have access to behavioral treatment. What that means is you no longer need to be eligible for that waiver, and there are no age restrictions for behavioral treatment under current Medicaid policies. So this is across the lifespan. It's also available for members with any diagnosis associated with deficient adaptive or maladaptive behaviors. It's not an autism benefit. It's where we see autism treatment most frequently under these services, but we would authorize and we have authorized treatment for other diagnoses. This is a fee-for-service only benefit. It's new, and typically in order to contract with a managed care organization, the department needs to have a lot of data about how a benefit is administered. So the department is operating this benefit directly as a fee-for-service only benefit currently. That means if you're in an HMO or if you're in fee-for-service Medicaid, these services are always directly billed to the department. Your relationship is with that provider, not with the HMO. Outpatient services refers to that level of care that our members would most commonly access for mental health services. So we have outpatient benefits for mental health and substance use disorder services, including assessments, diagnostic evaluations, psychotherapy, substance use disorder counseling, other psychiatric services. For children, we have a broad set of allowable places of service. So mental health services can be provided in the child's home, an office setting, school, other community settings. Mental health or substance use disorder diagnosis is required, not for a diagnostic evaluation, but for the psychotherapy services or the counseling services. This is delivered either fee-for-service or managed care. So that's where it does matter if you're enrolled in an HMO. This is a level of service that you would need to be coordinating with that managed care program. Medicaid also has an intensive in-home benefit. This is referring to that same type of service, a psychotherapy session, counseling session, but it's a benefit designed to authorize more intensive frequency of treatment. Members eligible for this level of care would need to have a determination of SED. A mental health or substance use disorder diagnosis is required. And again, what's unique about this is the number of hours you could receive is higher under this benefit, and additionally, a team-based approach is allowed. So under the outpatient benefit, it's really just that one clinician. Here, multiple clinicians, including paraprofessionals, can provide treatment in the home when supervised by a licensed professional. That's also delivered fee-for-service or managed care. Psychosocial rehab services is a broad term that describes 3 different programs in Wisconsin. There's the Community Support Program, CSP, the Comprehensive Community Services Program, CCS, and Community Recovery Services, CRS. As we've heard previously, CCS is probably the most high profile at this point. There's been a change in 2014 at the state level that really expanded access to that program. CSP is the oldest. It's been around, I want to say, since the 80s and is intended for designed to cover what's called the ACT model. So it's a historic high intensity program. If you were to kind of rank psychosocial rehab programs, CSP would be the highest intensity, CCS a mid-range, and CRS kind of a wraparound additional support program. Eligibility for these services are determined through a functional screen. Mental health or substance use disorder diagnosis is required. These are a set of benefits that are delivered fee-for-service only. And that is in part because these are all programs that are operated or administered at a county level. So here is a set of services where your initial contact would need to be the county, and the county will help, I think as Kenya's statement highlighted, determine eligibility for the program, connect you to that program, and the county will be the one who bills the Medicaid program for the services. Day treatment services is a set of programs that include partial hospitalization that are non-residential but provided in a medically supervised setting. It includes a set of case management, psychotherapy, medical care, and other therapies. Day treatment could occur in a child and adolescent day treatment program, a substance abuse day treatment program, or a medical day treatment program, often referred to as adult mental health day treatment. Members need to meet the day treatment admission criteria for one of those 3 programs. The child adolescent day treatment program includes a requirement for that SED criteria. A mental health or substance use disorder diagnosis is required. These are delivered fee-for-service or through managed care. And then finally, crisis intervention services. Crisis intervention services provided to a member in crisis or in a situation that they might progress to be in crisis if supports are not provided. Includes initial assessment, linkage, stabilization services. There are no diagnosis requirements. So the policies for crisis do describe what a mental health crisis is, but there's a recognition that a formal diagnosis is not a requirement to provide a crisis intervention, that those are really intended to be immediate services. They are also a county administered program delivered by fee-for-service only, so Medicaid will cover crisis intervention, but the county is the entity that's providing that service. Every county in Wisconsin has a crisis program. They should have a crisis hotline. Some counties have regional consortia to provide those services. So when trying to connect in crisis intervention, I think looking for that crisis hotline will connect you to that local resource in Wisconsin. I do want to follow up a little bit on diagnosis requirements. I think throughout this I highlighted where are there diagnosis requirements, where they're not. And I really do appreciate, Hugh, what you clarified and what I want to reiterate. An autism diagnosis does not disqualify anyone for any of these services. That should not be anyone's takeaway when they see a mental health or substance use disorder diagnosis is required. That does not mean an autism diagnosis, someone can't access that service. What it means is someone who has an autism diagnosis should have that diagnosis of the mental health substance use disorder co-occurring. And the expectation is that the provider is assessing that individual on an individual basis to determine that the treatment that they're going to provide will address the mental health or substance use disorder and is effective in the context of the autism disorder. So we're looking not necessarily to say you don't have autism, but that I can address the anxiety issue that is co-occurring with the autism, and I'm providing a treatment plan that acknowledges that whole person, that individual, through my approach. So that's the intent of our policies, and potentially speak a little bit more about how we try to look at that individual member. We have Dr. Leno to give us a few examples. Sorry.
Sorry. So the work that I have been doing, I am currently connected to Department of Health Services as a clinical consultant, primarily around behavioral treatment benefit because that's what I know best. I'm also still in the provider community as a training director. I'm a parent of a really old young man on the spectrum, and have served on the Governor's Autism Council for a lot of years, so I'm pretty familiar with a lot of these issues and also with being an advocate in this area. And have been thrilled with everything that I've seen the department doing in the last 4 years that I've been there. Around behavioral treatment in particular, that is a benefit that requires prior authorization. And some of these benefits require prior authorization and some don't. So that's, you can help clarify that.
Thanks for the reminder. In 2017, the department removed prior authorization criteria for outpatient, which means the benefits that I ran through, the only benefits that currently require prior authorization are the intensive in-home benefit, the day treatment benefits. Those are the two areas where mental health or substance abuse services have prior authorization.
Right. So that means for the others, providers can provide and simply bill Medicaid for those. Correct. Without having to go through a prior authorization process. For the benefits that do require prior authorization, the idea behind that is really to give the department the opportunity to look at the individual circumstances that are causing a provider to request services on behalf of a member. And really and truly in prior authorization, our goal is to have a good understanding of what is it that's going on with this member. And how are the proposed services expected to help improve their condition in one way or another. One of the things that I've learned in my work at DHS is that prior authorization and determining medical necessity isn't really about determining whether or not the member has medical needs. They're in Medicaid. We're pretty confident that most of them have medical needs. But we're looking at a plan of care to determine whether that plan of care makes sense and is likely to accomplish improvement of the symptoms that they're intending to improve. So it is very much looking at individual circumstances and really trying to look very holistically at what is going on with the individual, whether it's a child or an adult. Behavioral treatment is a lifespan benefit, so we're looking at everybody. In many cases, we know, so as behavioral treatment has evolved as a benefit, as Dan mentioned, that is predominantly serviced by providers that do applied behavior analysis, or ABA. Those providers historically were a lot of clinical psychologists. Now, increasingly, the providers who are doing ABA are board certified behavior analysts. That's appropriate if you're going to do applied behavior analysis. But those are individuals who don't necessarily have a mental health background. That is not part of the scope of training for people who get a certification as a BCBA. And so because of that, often when we're looking at plans of care that are submitted for behavioral treatment, we do see situations where individuals clearly have mental health needs, where we can see that perhaps it's an anxiety disorder, perhaps it's depression, perhaps it's an individual with reactive attachment disorder, somebody who has bipolar, something that mental health clinicians are trained and equipped to support, more so than behavior analysts. In those situations through the PA process, our PA reviewers, who are all BCBAs who have worked in the system in the state of Wisconsin, see that and recognize when that is perhaps beyond the scope of practice, and they often will push back and encourage those providers to, are you connecting this member with mental health services? And if you are, how are you coordinating? Because we really want to see that kind of the whole picture of the intended care is going to meet the individual's needs well, and address all of those pieces to the greatest extent possible. I think our goal with Medicaid is to make sure that, access issues are an issue for individuals with autism spectrum disorder. We know that there are parts of the state where it's an even bigger challenge. I feel like Medicaid has worked hard to make sure that funding is not the big access issue. We do know that there's a problem with enough providers that are willing to serve this population, enough providers that are willing to serve adults in this population as well. But I feel like Medicaid has worked really hard to make sure that Medicaid at least can come alongside from a funding perspective when plans of care are well designed to meet individual needs. So that's, a lot of what we're looking for. We really and truly do in behavioral treatment at least have a team of people who recognize when mental health stuff is happening and when it needs separate attention. And it is possible for members to have both behavioral treatment and potentially a mental health service happening at the same time. When that's happening, our reviewers are usually wanting to make sure that good communication is happening between those professionals, because that's how you have the best outcomes. But that is very much on our radar and very much what we're looking for with prior authorization. Other things that seem important? Yeah. Those are the things that I want people to know. I feel like I've been flying the flag to let people know that behavioral treatment is now a lifespan benefit, because my kid is no longer a kid. Okay, he's always a kid, but he from an age eligibility perspective would be in the adult system. And lots of other people who have been advocates for a long time have those old kids as well. So I'm encouraged that that's something that is available, so I want to make sure that people know that. Our biggest thing in prior authorization is really trying to get a good understanding of what's going on, so that we can make sure that good services are being provided. So that's sort of on the clinical side of this, is really and truly just trying to get an understanding of individual circumstances. We recognize that every situation is unique, every situation is complex, and the more we understand and are kind of on the same page with providers, we're in a better position to be able to say yes to those services.
So
yeah.
I think we did also want to just make sure folks had a chance to connect to resources. I think we've probably used the term complex or complicated quite a few times here. Right. We recognize we're not going to be able to cover all of that complexity today. Here are a couple resources that provide information and context both about the general Medicaid program. That's that first link that we have highlighted there. A link to our online handbook, which has much more detail about those coverage policies for each benefit. I will acknowledge up front, the online handbook is an old website and it is hard to navigate. So acknowledge that it may require a few clicks to get to where you're going in the online handbook. To support you in that process, if it's something you want to review and look at and gain a better understanding of, we have call centers. Forward Health has the member services center that I've highlighted. Just want to acknowledge for the providers, there's also a provider call center. So looking at that Forward Health website, linking to those call centers, you can have someone on the phone who can help you navigate some of those resources if that's something that you're trying to gain access to.
Mm-hmm. And in that online handbook, which I'm in, I think, virtually every day that I'm at the state for one reason or another, because that is our published policy for each of these benefits. the online handbook is designed with different sections and so on. The section that is labeled covered and non-covered services, I feel like usually is where you'll find the best description of what a benefit is supposed to be. There's a lot of other information because it's a policy manual for providers. There's a lot of stuff on claim submission and PA submission and things that may or may not be at the front of your radars, things that you need to know. But trying to understand the basics of covered and non-covered services is actually the thing that you're probably going to be, that's probably going to be your starting point in the online handbook. So I just mentioned that because it is a little tricky to navigate. That may be some of your most useful information when you start diving in there. So, okay.
Well, I'd like to thank you both very much. And again, hard to take questions from 700. So luckily they will be available here for a little while after the next break to answer these questions. I am curious though, just to sort of clarify, because there's a lot of different terms that have been used. So Forward Health Handbook, that applies to what you were talking about, the Badger Care Plus, SSI Medicaid, Katie Beckett Medicaid. That's all covered under Forward Health.
Yes.
So they don't go looking for a Badger Care Plus handbook. They're looking for the Forward Health.
Yeah, actually when they go on the site, when you choose the online handbook, the first drop down says, the first drop down box has different options, and you choose Badger Care Plus and Medicaid, and that covers all of the things that Dan talked about. And then your next drop down is the specific benefit area. So you might choose behavioral treatment. You might choose child and adolescent day treatment. Any of those benefit areas that he covered will each have their own policy manual. So.
And I apologize if I was dealing with other things. But so the behavioral health benefit under Medicaid, prior auth or no prior auth? How do they access that? Behavioral treatment.
Which is
Sorry,
ABA.
behavioral treatment, ABA.
Is PA'd.
Okay.
So and that one again is a fee for service. It's a new benefit, so you're not going to go through your HMO. They go directly to a provider that provides that service, and that provider submits a prior authorization to our team at DHS.
Fantastic.
Yeah.
I know that's one of the, one of those, figuring out the system, how do I navigate the system to get the benefit? Mm-hmm. So thank you so much for addressing those things. I'm hoping we'll be able to have the slides available if they've been okay. I've worked with DHS for a while and knows, some things don't ever leave the building. So that would be great. So we will work on getting all of the slides that are available to you posted onto the Connections website and with the YouTube website when we have the recordings done correctly. So thank you both very much. For the second part of this session, we wanted to make sure that we acknowledge that not everybody who has a child with autism and challenging behaviors is receiving a Medicaid benefit. Is that there are plenty of things that we can also learn about the system as a whole. And so to talk a little bit about how to talk with mental health providers, we've invited someone else who has been around with us since one of the beginning, 10 years of the community of practice. So Dr. Colleen Mortel.
Hello, my name is Colleen Mortel, and I am a psychologist and board-certified behavior analyst, and I'm one of these providers we've been talking about today, mental health providers. And my history is I've got a PhD in clinical psychology, and I wasn't really studying autism or developmental disability. And then I finished my postdoc, and I needed a job. And I got a job at the Wisconsin Early Autism Project. And I was very fortunate because basically they trained me very well from the ground up. They had me work with a variety of people with autism, kids back then, 3 to 6-year-olds, as a direct service provider, and then as a senior therapist, and then as a lead therapist. So I had an opportunity to learn a lot about people with autism, but under a very supervised situation. And ever since then, I've gone back and forth between doing intensive, what we used to call ABA, treatment with people with autism, and then more of a general mental health practice, still specializing in people with autism. And I don't know if I mentioned it, but I work at Psychiatric Services here in Madison, which is just down the hill from where we are. So the question is, why is there such a shortage of mental health providers who are knowledgeable about autism? I don't know, but I do think one reason is historical. And you know, all the speakers today have been talking about how to pay for treatment if you have an autism diagnosis or you have a mental health diagnosis. And historically, 25 years ago when I was in grad school and dinosaurs roamed the earth, it wasn't the way it is now. Basically, at that point, if a person had a developmental disability diagnosis, it was very difficult to get insurance, for example, to cover their treatment for their major mental illness. So if I sent in a PA for someone who had an anxiety disorder and autism, the reaction was, well, autism is incurable, so no, you know. So that's how it used to be. That never happens to me now. It just never happens. I've never had that problem. But I do think it takes a long time culturally to catch up, and so for mental health providers to come and specialize in autism, it's taken a long time, I think, for that. So, what constitutes, you know, autism-informed mental health treatment? You know, obviously you need education. You need an education background. And secondly, you need, I think, supervised training and clinical experience under supervision, as opposed to what happens sometimes where you're just, all of a sudden you have these people with developmental disabilities in your practice and you're winging it and figuring it out. You need years of clinical experience. For example, I get this question a lot. Someone will say, okay, so is this behavior autism or is this just rotten teenager? Well, you have to know a lot of people with autism and rotten teenagers to be able to answer that question. Lastly, I think the benefit you can offer is some knowledge about all the things that we've been talking about today, like who's available in your community that's good with autism, or what's Katie Beckett, So having enough of a knowledge about the general issues that you can be a useful resource. Okay, so that is what every one of us deserves and what we should have. We should all have someone with that level of expertise to treat our mental health or medical condition. But obviously, realistically, that isn't the case a lot. That's why we're all here. So when I thought about what to do with my 20 minutes, I thought maybe what might be helpful would be to talk to you about what I think about when I approach someone who has an autism spectrum disorder. And the idea behind it is that hopefully you can create a profile for yourself or for your child or for the consumer you support that would make it possible for you to communicate with a competent generalist in a lot of situations so they could be useful for your consumer. I'm thinking of situations like, corrections, where you might suddenly find your consumer in the correction system, or suddenly they're at the hospital for an emergency detention, or maybe they're at the hospital for a medical situation. In any one of those cases, there's going to be hopefully a competent generalist mental health provider there. So how can you communicate with them and hopefully make them competent to really help your consumer? And again, the real idea here is, how can we help the provider to adjust to the needs of the person with autism versus what happens so much is, the other way around. So this is kind of my list of what I think about whenever I'm treating a person on the spectrum. And kind of what I would ask you to think about as you introduce your consumer to your next clinician. So the first thing that comes to mind, of course, is language. The vast majority of people on the spectrum have some kind of language issue. If it's a really clear one, a competent clinician is going to understand that. But if it's more of a subtle language processing issue, they might not. So for me, when I'm meeting someone, I'm checking early and often if they're really understanding what I'm saying, if I'm really understanding what they're saying. So formally checking that and making sure that the communication's happening. Another thing that I'm sure you've all experienced, if you have a language processing issue, you're going to have trouble processing this quick language such as I'm giving you guys right now, where, you know, it's like sentence, 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 boom, 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 boom. If you're trying to process something from the first line, you're not going to get the whole long paragraph of communication. So I think in terms of, I think about what the point I want to make, how I can make it concisely. I make my point and then I stop. So if that's something your person would benefit from, that's the kind of summary you could give to your next provider. Next thing that I always think about is sensory needs. You know, is what the environment that you're going to meet this person, does it have a weird smell? Is it too hot? Is it loud? Is it too confined? Do they need to be able to move around? You know, obviously we all know that if those things aren't as they need to be, it's not going to be a successful interaction. So if you can kind of lay out what your person needs to succeed, then hopefully the provider can provide that. So speaking of functioning, I think the most important point is, what does this person need to function in this environment, in this particular mental health interaction? They will tell you. They will tell you what they need. And my policy is basically 100% responsiveness to what they say they need. So if a client comes in and says, it's hot in here, I say, it's hot in here? Should I open the window? Can I get a fan? Do you want to take your sweater off? We don't go forward until we've taken care of the heat issue, because I think what they're really saying is, I can't function, it's hot in here, you know. And people who are, neurotypical, usually they're like, well, it's hot, but I can do it. But I think usually when people on the spectrum voice a complaint, really what they're saying is, I can't succeed unless we resolve this. So, and sometimes we can't resolve it, but at least we stop and try. The next point I think is important is, people on the spectrum are more often making a decision based on their personal experience, as opposed to, I think, a benefit of being neurotypical is you often learn a lot from other people's experiences, so your decision making is more broad and shared. If you don't understand that, then I think sometimes the decisions they're making will seem wrong or illogical from the neurotypical point of view. But of course, people don't make bad decisions, right? They don't make a decision that's going to shoot them in the foot deliberately. So, and my clients often say, I am 100% logical, or I always make good decisions. And they are. And you have to understand that you're coming from two different points of view. So what example that came to mind for me with this one was, like when I was in middle school, I had older siblings, and they were all getting jobs. And I would watch them, and I'd notice, well, one of them detasseled corn, and one of them worked at the ski place. And I was like, well, what's a good job? And I was always gathering information from the world about what would be a good job. And I would ask my friends. And maybe even someone had a parent who had a business who could hire me. So that was how I chose my, high school job. And so someone on the spectrum, they don't usually gather information that way, right? They're more based on their own experience. And a conversation I had with one adult about this, it was time for him to get a job, and his parents, I could tell, were really fed up with the speed this was progressing. And they'd had it, which I could tell. And his process is he would search the internet, he'd find the right job, and he would apply for that job. And then 2 weeks would go by, and he hadn't heard, And I'm saying, maybe apply for 4 jobs. But, from his point of view, why would you do that? You'd already chosen the best job. So I think if you understand that part as a clinician, you're not going to keep kind of arguing this point of view, but you can kind of accept their point of view and go from there. The next one is supportive psychotherapy isn't necessarily supportive. So again, neurotypical people often come to psychotherapy for the experience of sharing what happened, a compassionate listener, and they'll say, okay, I don't know what to do, but I feel better because we talked about it. That's not necessarily going to be true for people on the spectrum. The relationship is still the foundation of any successful mental health encounter, in my opinion, whether it's a med check or psychotherapy or whatever. But you have to build the relationship differently. So, when I go out to the lobby to get my client, I'm excited to see them because I like them, and my face lights up, and they just look at me like this. Because my mere presence isn't exciting to them. However, once we get in there and we start talking about the things that they like and we do what we do, then they're going to enjoy it. This can come as a shock to people whose basically clinical approach is to be, warm and supportive. So another good question to ask is, if you yourself are the consumer or if you're representing someone is, what is your intellectual profile? Do you need to have some adjustments for that? So, if you have a neuropsych report, go ahead and send it. Send it to them early or bring it. If you have an M team that you can report, that you can show them, then they'll have a basis for what they're doing. Because again, especially with autism where there's splinter skills, superficially you can have a kind of a false impression of the person, and that can cause problems. So a mistake I've made several times, enough that I remember, is a client will ask me to write something down for them. I'll write it down, I'll give it to them, and they'll say, I can't read cursive. And I'm like, yeah. That's not good. I don't want to do that to people. So if you can load the person in advance with information about that, it's very helpful to them. Related is attention issues. Most people on the spectrum have issues with attention. So then what that means is that the clinician has to adjust my agenda to suit their attention. So this just happened to me yesterday, so it's fresh in my mind. I gave a young adult client one of those rating scales that we use, we use depression rating scales. This was an anxiety rating scale. So he did 2 or maybe 3. He put down his pen and he said to me, who's your favorite Muppet? And I said, well, let's wait to talk about the Muppets. We'll talk about it later, but let's wait. And then he did a few more, and then he looked at me again and he said, there are 20 of these. And I said, yeah, that's a lot. And he said, what if I did 10? I said, okay. And then he said, next time I come, what if I do the other 10? I said, that's great. Perfect. So, he knew, and he can advocate very well, and that worked out beautifully for us. But we have to know in advance a bit what kind of attention issues there might be. Help your clinician to anticipate and prevent behavior issues. Right. So if there's something that's going to trigger this person or cause them to have upset or behavior, if you can tell the clinician, they of course want to cooperate with that. If there's going to be, if a person is likely to be aggressive, that's good to know. But are they likely to be dangerous? That's very different. If a person is doing something, breaking things or yelling, but if that's as far as it's going to go, that's very different than if there's going to be dangerousness. Another thing that happens a lot is threats of self-harm. So some of my clients threaten self-harm quite a bit. Some of them are likely to follow through on that, some aren't. So, but that's helpful to know in advance, or, so you know how to follow up with it. this one's a little strange, but I want to mention it because it comes up a lot. I think that sometimes people on the spectrum have a different sense of time. So specifically, they loathe boredom. Like, bored is the worst thing in the world for them. So if you're having a conversation and they say, how many more minutes? And, you know, like the parent says 15, 20. That's not going to work. Like, that's way too long sometimes. So again, you have to stop and address the boredom and the time. Otherwise, it's not going to be a functional 20 minutes. On the other hand, it can go the other way, where, like, they come in, they start talking about something, 50 minutes goes by, and you say, well, we're out of time. And they say, but I had 4 things I wanted to talk about. Yeah. So time is very important, and, you know, discussing what we're going to do during our time, using a visual timer, you know, anything we can do where we are kind of joining them and sharing their point on his perspective on time. So I want to acknowledge that, again, we've identified a problem and we're throwing it back on the consumer and the family to fix it. I admit that we're doing that. And, you know, there are often situations where someone either can't do it themselves or they don't have someone who can do it for them. Nonetheless, I think there are many cases where a competent clinician can be successful if we give them this kind of support. On the other hand, sometimes they can't. And, you know, I think, like Hugh said, if you can figure out what your core needs are, communicate them to the person. If they can't adjust to those, you're probably going to just cut your losses and move on. Because typically, you know, people on the spectrum cannot compromise on their core needs. So it's not going to be successful. It isn't always the clinician's responsibility to meet your needs, because obviously they're human beings and they live under constraints like you do. But, you know, if they're not able to, it's probably good to figure that out and move on. For some reason, I always remember years ago, I took over a case from a retiring colleague, and when I first met the client, she said, I live on the west side of Madison and work on the west side, and she said, so my old clinician would meet us at the Perkins, the East Side Perkins, at 8 a.m. on Monday morning. Can you do that? I was like, no, I can't do that. That would take 3 hours and is not billable. So we're not, you know, they're not always going to be able to meet your needs. But if they can't, you probably want to move on. If your treatment fails, you want to try a different provider. You might want to try a different modality, like maybe art therapy or something different. And sometimes you might have to wait for a different window of development. So you don't have to give up, and you don't have to take it personally. A lot of psychotherapy and mental health treatment fails. So the last statistic I heard was that the modal number of psychotherapy visits is 5 visits, which means that half of all courses of treatment are shorter than 5 visits. Right? So very often it fails, you know, and it fails for reasons that aren't related to autism. It could be chemistry. It could be as we've talked about, sort of the lack of bang for your buck. If you have to travel a long way, if your treatment's expensive. So there's reasons why it just might not succeed. But if it doesn't, you probably want to keep looking. So I came up with a couple discussion questions. Should I throw those out now? Yeah? Okay. Okay. So my questions for you to discuss are, so what does autism-informed mental health treatment mean for you and your community and in your many of us support a particular person or persons. So are there situations where just a competent generalist is good enough and is useful? Or is that really not true? How does the combination of ASD, DD, and a mental illness change the treatment for the mental illness? So, you know, autism plus anxiety, does that equal anxiety? Like a horse plus a horse equals a horse? Or is it autism plus anxiety produces something different, like a horse plus a donkey equals a mule. Are they the same really, and are they treated the same, or are they not? All right. Thank you very much.
So I love some of Colleen's question and reflecting back to the earlier presentations by Daniel and Pam. Also, it might be interesting in your local sites to talk about, do you know where to find these resources? Do you know where to refer someone if they're looking for Badger Care, for Forward Health? Do you know about the regional centers for children and youth with special health care needs, of which there are 5 of them throughout Wisconsin that you can always refer to for help if you're a family or a provider? But do you understand your local system? Who do you talk to? Who do people contact? How do you find that out? And then are there ideas in your local area that have worked with different providers of mental health services and people on autism spectrum disorder or developmental disabilities? Are there things have you found success with mindfulness? Have you found success with different, like you said, different types of therapy? Maybe better for different people, is we're definitely not all made the same, and our brains definitely do not function the same. And so trying to find that fit, what's been working in your local community. So I'd encourage you to go ahead and take 10 to 15 minutes for discussion time at your local sites, then take a short break, take care of your needs. We will reconvene at 11:30. So we'll come back online with 11:30 with our last presenter. Very excited to welcome her later this morning. So go ahead, have your local discussions, send us your insights and ideas, and then take a break, and we'll see you all at 11:30. Thank you. Welcome back to the community practice on autism spectrum disorder and other developmental disabilities. Today we're talking about access to mental health services for people with autism spectrum disorder and other developmental disabilities. We are most of the way through our presentations today. We have one more to go. We've been having a really rich discussion at our site here, and I hope your sites have had a similar rich discussion. Before we get into last speaker, I neglected one thank you. This has been a group effort from the beginning. There has been a planning team that sat down, well, went over phone, of course, virtually met, to plan out exactly where should this focus go to. When you start off with the topic, mental health and autism, there's a lot of different directions to go. And so the way that this day came together was the planning team meeting and offering suggestions and talking through how it would go. And so I do want to acknowledge the planning team of Kim Coronado, Kirsten Cooper, Andrea Turtenwald, Allison Laresh, Peggy Helmquist, Deb Romiker, Jennifer Helt, Rachel Kramer, and Ann Harris, who has stepped in to help us evaluate what we're doing. So we really appreciate all of their support. Also, if I could have just a moment of your time to do a proud dad moment. Is that all right? Can I do a proud dad moment? Okay, people are shaking their heads. So I have a son who is on the spectrum. He's now 21 years old. This morning, he got himself out of bed and he went and picked up somebody who wouldn't have been able to come to the community practice site without transportation. He never hesitated. He said, of course, Dad, I would love to do that. And I just want to let you know how proud I am of that kid. Because that ties in with families as well. And so we wanted to close with how can we support our families? What is going on and what can we do for these people that are just so vital to our kids' lives and who we keep asking to do more and more and more. And so we have Anna Moffett, a parent peer specialist at Wisconsin Family Ties. So welcome, Anna.
Thank you. Thank you very much. I just want to start by saying that public speaking is a little bit of a stretch for me, so please be empathetic. I continue to try to do it just because I figure you got to try, that's how you get better. So very quickly, I'm just wondering how many people in the room are clinicians? Okay. How many people are educators? Great. And then parents? Okay. And then individuals that would want to disclose that they're on the spectrum or mental health? Okay. Excellent. Okay. So I was hoping we'd have like a wide range of people, and I'm sure overall the different venues, this is probably similar. Basically, what I want to talk about today is really to address some of the challenges that families face working with different providers and in the community. I want to share some ideas and strategies that I think could be helpful or beneficial that I have gained through my own lived experience, as well as working with probably hundreds of families at this point that have children that either have mental health challenges or children that have behavioral challenges, and many times that we've talked about that can be in combination with autism spectrum disorder as well. And then also to talk a little bit about parent peer support and the benefits of parent peer support, because I do think similar to peer support, it's an area that's just becoming more recognized and being more validated within the service provider community. So those are kind of the goals for me. So just basically to talk a little bit about myself, my journey really started from, I was a stay-at-home mom. I used to be an elementary educator, and then I had 3 children quite rapidly. I had a 1-year-old and then also was expecting twins. And during that time it was a pretty high-risk pregnancy, so it was a little bit traumatic having a 1-year-old and being on bed rest. And so, you know, the day came, my twins were a couple of months early, spent a little over a month in the NICU, had some complications, and then they finally came home, and so I had my 3 kids under 2. But I always figure if I got through that, I could really get through anything, because that's just really a lot to handle. So my youngest son, Felix, and that's where a lot of my experience come from, was a kiddo that was developing what we would consider appropriately or developmentally appropriate, and then he did have regression at around 18 months. Within a few months, it was recommended in the birth to 3 that perhaps I should have him evaluated to see if he has autism spectrum disorder, and so by about 2, actually here at the Weissman Center, he received his first diagnosis of autism spectrum disorder. I can say at that experience, it was really a life-changing moment for me. And I think unfortunately, for me and my son, that was a time that I was by myself. And I think that's pretty similar for a lot of our families. You end up in situations where you hear really dramatic and significant information and you feel very much alone. I think what I would like to talk about, and we talk about this at Wisconsin Family Ties that many times, mental health diagnoses and other diagnoses are kind of these conditions without casseroles. And so when you start disclosing to family or in the community, it's not the same as if you would go out and say, my child was just diagnosed with leukemia, and there's this wraparound support for you. A lot of times there's almost a step back, oh my gosh, okay, I need to go, because people aren't sure how to react. And so for me and like many other families, this leads to a lot of isolation. And then I think that isolation becomes exacerbated because once you walk away with a diagnosis, there's a very quick period where you're then pushed into the treatment cycle. And many times when we think of treatment, especially for children with autism spectrum disorder, it can be very time-consuming, many, many hours. And when you're in that process, a lot of times you're just going from clinic to clinic, or you're sitting at your home while providers come in because of how the laws are structured. And I found even in the clinics that I was going to, we have so many laws in place that would even discourage us from talking to the other people within the clinics because of HIPAA and other things. And so you're kind of sitting there by yourself, and many times maybe sitting in very similar situations but not being able to interact because of how the systems are set up. It was really at that time, birth to 3 is where, as parents, once we get this information, I'm just going to say, like, when I say parents, I'm really talking about parents, caregivers, families, just so I don't have to say all those 3 words at one time. And then when I talk about children, I'm really talking about children, youth, adolescent, that I'm just going to use those, otherwise it wastes a lot of time on the words. But that's where you're really thrown into then not only doing your treatment, but then you're also on this, what I would call an independent study, where you're beginning to have to educate yourself on all the different aspects of the different conditions. And then as you phase out of that, then you're thrust from the medical system into the school system, which comes with an entirely different language, processes, providers, you name it. So it's really this thing where we're continually having to re-educate ourselves around different things as our children grow older. And so, but really through that, you know, I'm extremely privileged. I have a spouse, I'm middle class, I'm white, I live in Madison. That even coming to the table with all those privileges, it was overwhelming for me. And so I wanted to use my experience to start helping other families, which led me to Wisconsin Family Ties as a parent peer specialist, because then I could begin to reach out and work with other families and support them to make sure that their children were getting their needs met to the best of our abilities. So basically around parent peer support, I just want to talk briefly about that. What do we do? What do I do as a parent peer specialist? Well, pretty much a lot, or anything, really. We really do what families need in the time that they're in. So sometimes we're doing crisis work. Sometimes we might be doing systems navigation, whether that's working with social services, whether that's working with medical providers, whether it's working with school staff. to help families understand the systems that they're in and be able to access the services they need. We provide a lot of emotional support. It's really a space for families to come and share their stories, and it's a time for them to talk about what they're going through, and we're there not to judge anybody. We're not there to fix anybody. We're just there to listen to them and empathize and be with them, sometimes in places that can be pretty dark. And then we're definitely there to empower families through skill building. So really trying to teach families what are different things that you can use that can leverage the skills that you bring to the table, and then also increase your voice and be a better advocate for getting what your children need when working with different systems. So I want to talk briefly about the challenges that some of our families face and many of our families face. And I think the biggest one I already talked a little bit about when I talked about my own experience is that a lot of our families feel very isolated and lack meaningful connections within the community and sometimes even within their own families. And I think this challenge is really driven because a lot of children with ASD and other mental health challenges may react to things in a very unexpected way. So people might not feel that it's appropriate to be doing a certain thing in a certain setting. And so what a lot of families choose to do is just pull themselves out of that for fear of judgment about them or their children. You know, and this also becomes a thing that many times families are just plain out asked to leave because of behaviors that might be displayed by their children. I think a place where this comes up a lot for families is in the school setting. For a lot of our children, school is one of the few places where they're still accepted and they're required to be. And so there can be a lot of conflict because the children need to be there by law. And so I find that to be a place where I experience a lot of conflict between parents and school staff. I would say another thing is the stigma that's associated with having a child with mental health or behavioral needs. And we definitely have seen this play out at a national level amongst our leaders and how they talk about mental health and really how they scapegoat individuals with mental health needs or behavioral differences when things come up in the media. And so that's very challenging. We see it in the language that we talk about people, whether we talk about people being crazy, a nutcase, a schizo. A lot of kids might be referred to with the R word, that these are still things that are very much out there, that it makes it difficult for families to come forward and then share what might be going on with them for fear that they too, or their children will then be stigmatized. I mean, I can think of a family that I just recently was working with that they had different learning needs, but they were demanding that their child not be in a class that was supported with special ed teachers because they said, if I do that to my kid, he will be bullied and alienated by his peers. And it was really, I understood her concerns. That was a really hard choice to make. I think there are other barriers. I think there are barriers that we all face in the community, whether it's access to employment, housing, transportation, time, money, financial resources. But I think all of these challenges are amplified when you have a child with autism or mental health challenges. And when you combine them, I think that increases it, and it makes it very, very difficult for families to do things that some folks would see as, what's the problem? It's no big deal. Why can't you get your kid to therapy 2 times a week? Or, you know, why do you keep missing appointments? I would also say with that, a barrier that we don't talk much about, and it kind of goes back to the stigma, is many times children and youth that have mental health challenges or autism spectrum also have parents that may have similar mental health challenges. You know, I myself have an anxiety disorder, and that can impact what I might be available to do on any given day. And so I think that is something that we also have to take into account. Oops. I think other challenges are that many families and children have experienced failures due to broken systems, which lead to mistrust. I can speak to this personally, and I can speak to it through my families, where families will be given options for different support, and then when they call, oh, sorry, you don't meet the eligibility criteria. Oh, yeah, we'll have that, but it's going to be a 2-year wait list. You know, there's different excuses that come up, or not excuses, but reasons why they can't access that. And so people do get mistrustful of whether things are going to work. There's also issues too around sharing information and disclosing information that could then come back and be detrimental to your child and your family because of some of the policies that we have in place. So I also think in the school setting where I see this a lot is around seclusion and restraint. A lot of our kids with behavioral challenges are disproportionately exposed to seclusion and restraint, and so really you have not only the children that are traumatized, but you have families that are traumatized because they're having to deal with knowing that their child is going through that. And I think it becomes even more difficult too, I can think with my son who doesn't use words to communicate, that when he comes home he can't even talk about what that experience was like for him, and so it can be a challenge. I also think families face assumptions that may be inaccurate, and many times are inaccurate. One assumption I hear a lot is, oh, they're just acting that way and doing that because of all the problems at home. Or, you know, oh, they just do that because nobody's following through at home. And that just, in most cases, that's not the case. I mean, kids will present across the different areas, whether it's community, school, or at home, with similar behaviors, but sometimes I think we get to a place where we point fingers at different places and we start thinking things about people that aren't actually reality. I think other things, like I said, people who always miss appointments, why can't they just get to these appointments? They don't want to work with providers. Maybe that's the case, or maybe it's that the family wasn't really brought into the discussion to begin with, and they don't really feel like those are supports that would be helpful for their child. And maybe the child doesn't want to engage with those things, and so there could be different reasons. So I always think people need to check their assumptions with the families and ask questions. You don't know what you don't know. I think this is a huge thing that providers lose sight of, is that for our families, again, like I said at the beginning, we're functioning in so many different service delivery systems, and each of those systems come with vastly different, like I said, processes for accessing services. I think a huge thing is the vocabulary. Each system that you're in will have a very distinct vocabulary or jargon that you have to be proficient in to communicate many times with people, and sometimes that jargon gets reduced into acronyms, which is even more difficult because then you're using acronyms that may mean different things depending on the system that you're in. So I think of the juvenile justice system, and we'll talk about HDP, which is the home detention program. But if you're in crisis services, HDP may be hospital diversion program. And so when you're sitting at that table as a family member or even a youth, and all of a sudden this stuff is getting all thrown out there, it gets very confusing. And that's just how we're talking about it. That's not always thinking about what families have to do to access services within those different systems. And so just thinking about that, I think, and this came up earlier, is if systems could work better together to streamline that, so that we're not expecting people to function in each of these silos, rather, and really bring it together so you can have that and make it easier for families to access services. And I would say a lot of times families are really exhausted and traumatized by a variety of different things, like I kind of talked about what might be happening to their child in different places, whether that might be school, and sometimes that might even be with treatment. that can be difficult. And most of our families are providing care for children on top of doing all the other things that are expected of you, like taking care of a household, having employment, many times taking care of other children, and many times those other children might also have other challenges themselves. And so we always have to be mindful of what expectations we're putting on families and if they're actually doable. So those are some of the challenges. I want to talk a little bit about what we can do to help families. I think first and foremost, this has come up a number of times, is to build those meaningful relationships with the families and meet them where they're at. And that can be difficult, I completely understand, for service providers and other people, because you're pigeonholed into time slots and that type of stuff. And a lot of relationship building takes place over time with meaningful interactions, and we're not always allowed that within the systems that we function in. But I do think that's critical. And again, really meeting people where they're at. So, and I think that goes back, and I'll talk about on the other slide, but about being family driven and child focused or youth focused, because you know what you don't want to do, and sometimes I do see this, is providers will come in and say, oh, what you really need to do is horse therapy. This just came up on the CCS array. I think it's going to be really great, but maybe you don't know that that family doesn't have a car or a vehicle. So suggesting something like that where they wouldn't even be able to access that service would not be helpful to the family. And so you have to find out where families are at, and you do that by getting to know them and building trust. Don't make assumptions. I talked about this before, because this is a big issue that comes up. And be an active listener. And I think that's a challenge that we all have, is actively listening to people. I think a lot of us, myself included, will get into a space where rather than listening to someone, I'm kind of half listening, and maybe I'm thinking about what I have to do later, or maybe I'm thinking about what I'm going to say back to that person. But trying to rein your brain in and stay focused on what people are talking about. And so with that, you know, critical skills, and a lot of you probably are versed in it, but you know, using paraphrasing, open-ended questions, empathetic listening, so that you're getting a better understanding of what families' needs are and what their wants are. You know, so an example of that might be, you know, a lot of times I talk with parents that are pretty upset, and I feel bad for people who work in schools, but like I said, I just feel like this is where a lot of our children and youth are for a lot of part of their day, so there just are issues in our schools in general. But they might be going on and saying, oh, that teacher, they don't know what they're doing. They keep making my kid do this, and then all of a sudden I found out they got a new teacher and they don't know my son at all, and now they just got suspended because they hit the aide. And so they might be going on and sharing this, and something I might say to them is, it sounds like you've been having to deal with a lot of changes at school, which can be challenging. I can see you're really frustrated. What do you think about that? And at that point, I can kind of say back what they've told me, and then kind of test what I think might be going on. And you know, that parent may very well be like, oh, no, I'm not frustrated at all. Like, I'm just heartbroken. And I'm confused, you know, so checking to make sure you know what the issues are and how you can help them. I can't say enough to, when we're being an active listener, to do the tell me more about the situation, and making sure that you really are there and present. I think another thing that what we can do to help, but it's really difficult for what I consider service providers, is change the power differential in the room, and provide oversight. Many times the structures are built upon, and I can say this, whether it's CCS, CLTS, schools, medical places, many times it will be one parent and then 6 to 12 providers in one room. So that you're already putting the parent or the youth or the child at a disadvantage, because you have all these people there and you might only have that one voice for the parent. And so I think how can you help in that situation is really by encouraging parents to bring in other people that know their children. I think one of the first things I talk to my families around IEPs is, you know, you can bring in anybody to an IEP meeting that knows your child. And they're like, what? No, you can't do that. I'm like, yes, you can, 100%. You can bring in your next door neighbor, you can bring in an aunt, you can bring in a grandma, you can bring in your occupational therapist. You want those people in the room because you're really, like I said, you're not coming at it as it's just me in this room with all these other people. You kind of have these equal balanced teams. And I'm not saying it's us versus them, but there's a little bit of, you want people who know your child in different realms outside of school. And you also want people that can support your voice and who know you to get you more engaged in the process. And I would say 100% it does provide oversight. Having more eyes on a situation not only brings up more solutions, but there's also more oversight and accountability for things that are discussed. So really encouraging families to bring more people into the situation. What I also say with that is continue to tell your families that you're the expert. You're the expert. Too many times we tell families we're the expert on their kid, and that's absolutely not the case. Families first and foremost know their children the best. They may not be knowledgeable about everything that other providers are, but they do know their child. They know what their needs are. They know what their wants are. They know their strengths and they know their challenges. To always be reminding families that you are the expert. I think another way we can help is strength-based language versus deficit-based language and planning. I really like using positive student profiles at school. I also just really talking about and using language that's not so deficit-based. We use that a lot. And so examples of that would be normal, we would use normal or abnormal. Well, I think a better way would be we could talk about like normal behaviors versus abnormal, or we can reframe it as expected behaviors versus unexpected behaviors in a situation. Manipulative, that's a big one that comes up. We could say they're not manipulative, but they're really good at getting their needs met in a situation. Aggressive, I hear that a lot. I don't like that personally because aggression to me says there's an intent to hurt somebody, and I know in many cases that's not the situation. What you're really talking about is someone who's physically dysregulated to the point of physical activity. And also, another thing I hear a lot is attention seeking. That's not really the case. I think attention seeking is really more somebody who's seeking connections with others, but might have lagging social skills. So I think there are different ways that you can look at behaviors and reframe it so that we're not using such deficit-based language that's also really heavy on assumption, especially assumptions that may be incorrect. Keep the family, child, youth at the center of all planning. This is something that's a huge shift in how we have done things in the past. In the past, it's kind of been, what do we have to offer families? Okay, look at your menu of offerings. What would you like? Okay, now let's do a service plan. But what we really should be doing is starting with the family front and center, the youth, the child. What are your goals? What are your dreams? What supports do you have currently that can get you to those goals? And then filling in, okay, what do we need to get you to where you want to be? What services do we need to be putting in place? So it's really flipping that model around so that the family, child, and youth are at the center of the planning. I think it's also critical to connect families with other programs or services that can assist and empower them. And in thinking about that as providers, really looking to natural supports as much as you can. I think a lot of times our families get connected to different services and supports, but they're time limited. And we have to be thinking about long term. Because what happens after 6 months and a kid is discharged and that support is gone? So we need to be thinking about what we can do that's long-term, natural, outside of certain service providers. I also think when we're talking about this, and I see this going on at the Children's Museum and other places, are creating spaces that are inclusive and developing those spaces based on feedback from children and families that are impacted from autism spectrum disorder or mental health. Don't make this space about what you think it should be, but bring in people who are actually using that space. And so I say that because of the Children's Museum. It's very difficult for a lot of the community spaces that we have to be I know for my child to be part of, because they're totally not set up for what he will tolerate. And so I think really thinking through how we can create more inclusive spaces. Schools is another place. I mean, it's really, not conducive for people with sensory differences, language differences, you name it. And so how do we make our schools more inclusive? And then last I would say about this connecting and empowering families is really being allies and not just creating spaces, but also pushing back against policies and practices that we know are harming our children and youth. And I think front and center what I see right now in something I'm really involved with is the decriminalization of disability and mental health challenges. Hugh quoted the statistics, which are completely disturbing, should not be happening. And so what are we going to do as a community to change that? And, you know, personally, I took a tour last year of Metro High School. And so in Metro High School is the high school where youth that are incarcerated attend in the Dane County building, Dane County Jail. And one thing that they shared while they were on the tour is that they were had just developed, and they were really proud of this, and they were really proud about how they were talking about how they just created their first sensory room, because they were having all these individuals that were having sensory processing issues, and so they needed a different space than the open space where there were all these bunk beds. And you know, although I guess I can appreciate that they were creating a more inclusive space, the question had to be like, why the hell do we have people incarcerated that have significant sensory needs, and what does that tell us about our justice system and what's going on? So it was eye-opening for me. So just in conclusion, just talk a little bit more. So I'm a parent peer specialist. Like really, these are the key areas that we really focus on. Our main goal is always to help families, help them make sure that their child or youth reach their potential in any way that we can do that. We really spend a lot of times, I work with a lot of providers to better understand the parent perspective and what they're experiencing, so that providers and families can work together in a more collaborative way instead of being combative or coming at each other with less understanding of where the other person is at. And then I think a big part, and this comes back in a lot of our feedback, is just building that relationship with the family and helping families understand that there is hope for them. Sometimes families experience some really challenging situations, and because of the isolation that they might be experiencing on top of other challenges, you can get into a place where you think things might not change, and things will always continue to be the same. And so just really being there and making sure families know that, you know, by working together we can make things better in their lives, and make sure, again, that their children or youth reach their potential and get to what they're dreaming about. So that's all I have to say.
Before you leave the microphone,
Yes.
one of the questions that I would have is, okay, now you've talked about how you're supporting these parents, and that Family Ties has other parent peer specialists that you have trained to help support the parents. If somebody's listening and is sitting there going, wow, I would really like to talk to one of those people because I just don't know what's going on and I don't know what to do next, how would they get in touch with a parent peer specialist?
Hugh, do you want to answer this? I mean, my short answer would go to our intake line and go visit our website. Go Google Wisconsin Family Ties. I would say our intake coordinator, our connection coordinator is embedded on one of the tabs.
Yes.
I don't know which one though offhand.
And the phone number, there's a toll-free number, 800-422-7245, I think. I am so not going to be able to remember that to repeat it to you. There was too many pauses in there. It's an 800 number, but there is a website if you Google Wisconsin Family Ties. You have a direct line. We know you have a bat phone that you just pick up and you call. But so parents and families can contact Wisconsin Family Ties and see if there's a parent peer specialist who's going to be able to help them. And I know that you just relaunched your website within this past year, and there's a lot of new stuff and good stuff going on there. So I would encourage visiting that website, finding the 800 number, reaching out for that help. They are there to support families. So I would encourage.
Do you want my question?
Yeah, I would love your question. Please.
I thought,
Come back over this way.
what is something that you could take away and utilize in your job or your life from the discussion?
Excellent. So good wrap-up question. What is it that you can take away to your life or your job based on today's presentation? That's a wonderful wrap-up question. Also, before we break for the final time today, wanted to again extend thanks to our awesome site hosts who put a lot of work into putting this day on, the planning team, the support from the Weisman Center and University Center for Excellence in Developmental Disabilities and the LEND program. And to let you know that by virtue of attending here, you have now been placed on the listserv for the Community Practice on Autism Spectrum Disorders and Developmental Disabilities. You can unsubscribe at any time. It is through a function called WISC List through the University of Wisconsin. Every time I get a notice from somebody, there's always that click to unsubscribe. But I wanted to preview that coming up in April will be our next large group gathering. It's going to be in the Green Bay area, and it is being planned with Matthew and Mitchell Labarge from Speaking About Autism, LLC. They have been responsible for finding venues, providing the content. It's been fantastic working with them. They have been participants in the community of practice for the past few years, and we are excited that they are stepping forward and planning an event for the community. So really excited to invite you all to the Green Bay area this spring. We'll try to get you advance notice so that you can plan your sick days accordingly. So I would like to again thank all of our speakers. Fantastic job, fantastic information. I hope your site discussions are going well as our discussions. We're going to end the broadcast now. Site leaders, please return your sign-in lists so that we can make sure people get credit for CEUs when needed, and so we can track attendance so we know how we're doing. You will get an evaluation feedback form within a week. We really appreciate your feedback and your insight. Thank you so much for joining us this morning. We're going to end the broadcast now. Thank you.